Welcome to the No Plateau podcast for stroke and brain injury survivors, their caregivers, and the therapists helping them to break boundaries in their recovery journey. Hosted by Henry Hoffman, occupational and clinical therapist, this podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. And now, here's Henry Hoffman.
Hello, everyone. Welcome to another episode of the No Plateau podcast. I am your host, Henry Hoffman, and excited to be with you today. Today on the podcast, we are literally going to be talking about something different. Ice balls. Yes, actual ice balls. But instead of cooling your drink of choice, these are forming around the nerves during cryoneurolysis and create a temporary reset in spasticity. To help us understand all things related to cryoneurolysis, we have a thinker and a clinician who's shaping the future of rehabilitation medicine. Dr. Paul Winston is a Canadian physiatrist and clinical associate professor with the University of British Columbia's Department of Medicine and a past president of the Canadian Association of Physical Medicine and Rehabilitation. He's published research on innovative treatments and diagnostic techniques and is a co-founder of the Canadian Advances in Neuroorthopedics for Spasticity Consortium. He helped develop cryoneurolysis as a groundbreaking, minimally invasive technique to reduce spasticity and restore meaningful movement for people living with neurological disabilities. We'll be talking about how cryoneurolysis works, why it matters for rehabilitation, who it can help, and how it fits into the broader landscape of spasticity care. Without further ado, Paul, welcome to the No Plateau podcast. Thanks for joining me.
Thanks so much. And I laugh at your introduction because it's like an occupational therapist. It's this really long explanation for what you do. Nobody gets it or understands what it is.
Yeah, exactly. Good luck trying to say, what's occupational therapy? So before we dive in, let's have you start off by expanding more about your wonderful personal and professional background.
So I'm a physiatrist up here on the west coast of Canada. I moved here after residency, where I did all my training back in Ontario, close to where you grew up, actually, I heard. And many people know, and it is sort of a relevant factor, that I actually grew up in the dance world. So I was a dancer. I went through our National Ballet School. My whole life was that before I even thought of going to university. So for me, rehab and medicine sort of really clicked when I discovered it. And my sort of whole career path has been really the theme of your talk of No Plateau. Because in medicine, we are taught in book algorithms, but that doesn't help the individual statistic in front of you. So I would say that the path of my journey has always been, I'm not in a big academic center, I don't have any academic supports. It's patients coming to the way they do in rehab, and they didn't get better from the traditional techniques. So I see people with musculoskeletal injuries, complex regional pain syndrome, spasticity, and just not happy with where they are. And I found that when I went to the literature, we have very little literature in rehab to support what we do, even though we know what we do works. So I think my whole career path has been a series of serendipity in meeting the right person and discovering something and following that path, despite other people not believing in you, because you get this immediate result. And being someone from a dance background, literally watching someone improve better and enforcing change has been what has kept me going. So seeing that I could actually take someone who's been giving painkillers with a non-functional hand and having an OT call me, and then, a month later we have them with a functioning hand together. Mm-hmm. So for me, it's about visual observable changes, because the vast majority of medical literature is non-reproducible and it's a statistical chart. But as an OT or a physio, that's not helping you in your day-to-day function when you suddenly presented with a patient who's also an amputee and also has diabetic neuropathy. There's no guideline. So the simple answer is my career path has been a series of patient stories of how do I get the patient that I'm treating right now to where they want to be. And I think that's the purest answer I could give.
Excellent. Well, I appreciate that. And obviously, I originally saw your work through LinkedIn. You're a great promoter and a purveyor of communication. And I was fascinated with, because I didn't know much about cryoneurolysis. And I was fascinated to dive deeper because of the videos that you had on LinkedIn. So I appreciate what you're doing within the profession. So let's tee it off there then. A vast majority of the audience, whether it's patients, caregivers, and therapists, some of them don't even know what cryoneurolysis is. So
Mm.
one of the big sources of confusion is, when you hear the word cryo, you're thinking of ice baths, cold packs
Mhm.
as a therapist, which is not the same thing. So how is cryoneurolysis fundamentally different from cryotherapy that we're as therapists
Right.
know? How would you clear that up?
So excellent. So cold has been a treatment from the Greeks and Romans, and before going up to a cold winter day or mountain. So that is a large area to cool down temporarily an event to stop inflammation or pain. The cryoneurolysis itself was started to be developed, in the 50s and 60s, looking at making temperatures very cold with refrigerants, basically. So the first cryo was really being done in Oxford around the 80s. They developed the first pain technique. And the idea was if you put a gas through a tube, so nitrous gas, CO2 gas, argon gas, the gas will, when it goes through a tube, you get an interface between gas and liquid. And when you pass through a portal, you drop the temperature to the boiling point. So we use nitrous gas right now, it's minus 88 degrees, CO2 is minus 60, and argon gas is super, super cold. So when you simply pass gas through, it gets cold. So if you look at any hospital, if you see an oxygen, big cylinders at the back, you'll see pipes. Even in the middle of the summer, they'll be frozen. There'll be ice balls. So all you do is you're putting gas through a tube, and the tube gets cold. That's it. But the tube goes so cold at minus 88, it causes water around it to adhere. So if it's outside, you'll see an ice ball. But in your body, you're actually causing liquid in the body, in the cells, to run out. And what they realized with pain when they started is if you have cells that are full of fluid and you take the water out, and then when you thaw, the cells will swell and burst. Apoptosis is the scientific word. So the myelin and the axon will burst. The nerve is still there. So if this is the circle of my nerve, you'll still see the structure on your MRI ultrasound, but all the soft tissue connections, a lot of the structures, the collagens, all those tissues are still there, the blood vessels, but the actual axons and myelin will be destroyed.
Yeah.
And they will stay destroyed for the length of the lesion and how long the nerve is. So we know that if you destroy a nerve, you destroy its ability to conduct electricity. So when it was started for pain, it was literally taking away the ability to have pain. But the nerve will regenerate. So in like a facial nerve, they were looking at 3 to 9 months for relief. So that was being done in the pain literature for many years. It never caught on fully, but there's been great people. Eastern Europe is actually the lead of it. And so cryo being used for pain is nothing new, and it's FDA approved, and there's reimbursement. So cryo as a pain technique, it's used all the time in cancer. So if you have a tumor, you use a much colder gas. You use the argon gases, which are so cold they kill all the tissue because you want to get rid of it. We do cardiac ablation. When they do surgical procedures now on children to rebuild their chests, they freeze all the nerves to get rid of them so that they don't have pain after the surgery. So cryo was a pain technique done by mainly anesthesiologists and some surgeons. So that's how it was unheard of until we kind of came up with this idea in 2017.
Yeah, well, I appreciate that because we'll dive into spasticity in a little bit, and plus a little bit more about the anatomy of what you're referring to. But how did it become part of your practice?
Mhm.
If you can share a little bit of that story.
I told you I did come back from the stage, right? So there's a really amazing meeting that takes place in Versailles, France, at the Marie Antoinette Theater. So the Palais de Versailles. And I was there in 2017, and I realized that the Europeans, the French, Italians, and Belgians were light years ahead of North America in terms of managing spasticity. They had a huge program with surgical interventions. So they would do nerve surgeries and many more tendon lengthenings. It's very hard to get surgeons in North America to do spasticity surgery. There are very few that can. And what I discovered was that they had a program where they started a program of diagnostic nerve blocks. And that's sort of the key. So when you see a spastic positioning of a hand or a wrist that's in a certain position, or like this more typically, before they do an intervention with Toxin, they would have a multidisciplinary meeting with all their therapists, and they would analyze the movement. And then you would take a needle, a little stimulator, and you would get, say, the brachialis to stimulate. You put in some lidocaine or dental freezing and see if the arm will extend. If the arm fully extended, they called that a fully reducible deformity, which many spastic patients have. First thing in the morning, if you're working with your OT, you can stretch it out, but then an hour later, it's here. So reducible deformity is when you do a nerve procedure or a state of relaxation, it goes full. But there are many patients that can't. They're either rigid or they just get a little improvement. They couldn't tell if it was truly fixed or not. So a nerve block tells you if you can extend it or not. And then the French were going in and doing, if toxin didn't work or an alcohol like phenol, they were doing a neurectomy, a partial neurectomy, which they had a limited choices of what they could do. And if not, they did reconstructive surgery. But it was this algorithm. And I was watching this meeting and it was just crazy. And so they did it with electrical stimulator. It took a long time. It was difficult. So I called my colleague who's an anesthesiologist here in town. And I'm like, Dan, like, this is crazy. Like, I literally, my life has just changed. Like, I feel, I'm like crying for every patient that I have not treated well enough. They could have been so much better if they had this team of European doctors. So 2 weeks later, we are in Dan's office. I had no idea his wife's name was Marie Antoinette because her name is Tony. And they both speak French farmer backgrounds. And we did our first blocks. But what I said to Dan was, you do ultrasound guided anesthetic blocks. And for pain, I do ultrasound guided spasticity. The French aren't doing that. That taught us, and it's really slow and cumbersome. So we realized when we looked at those nerves, we could do it in 1 minute. What took like a half an hour with ultrasound, boom. So we did our first 2 brachialis and the arms went open. And we did our first 2 calves and they went fully black and clonus was gone. And we like screamed and the patients were like, what just happened to me? And so while we're doing it, Dr. Winston goes, Paul, that's just the coolest thing ever. Why don't we just cryo them? And I'm like, what? And he's like, yeah, we could just cryo it. It'll last much longer. I'm like, Dan, you're a pain doctor. You cryos for sensory nerves. And he has a machine built in 1980 from Oxford. And he goes, motor, sensory, motor, sensory. You can stimulate both. We just generally don't because people are worried about weakness. But for your patients, it doesn't matter. So I thought he was insane. But the patients were like, this is so cool. Look at my arm. Look at my arm. I'm moving. So we spent 6 months looking, like, where can we do this? Is this ethical? Can we destroy a nerve? And we found one case report from the 1990s on an operator with fluoroscopy in an MS patient, and no one ever mentioned it again. So we had to really think about ethics. So we got the patients together, and 6 months later, we treated the first patient. And it was a man 2 years post-stroke. He had been my patient in the hospital. He'd been getting botulinum toxin, better, but just not functioning. So Dr. Vincent did the treatment. I wasn't there. And he came in and he just went, boom. And I was like, oh my God. Like, I actually screamed because he had full range of motion. He had a 40-degree contracture on his own. He could do full range.
Wow.
And then he's like, yeah, you know, I can pick up my grandkids now. I can do all these things. I'm like, how is that possible? How do you have more power? Because he can now fully extend and move. He's generating power. So at the beginning, we had the one nerve. And then I started taking the toxin I had and moved it to the other muscles so that he'd have better. And then Dr. Vincent did some calf muscles. And over the next 2 years, we had to find how to do it because it didn't exist. There was no literature. There was no textbook. So Dr. Vincent is an anesthesiologist, you know, at the end of his career, and he became a spasticity doctor. So he'd show up in clinic with me and we would ultrasound and we'd like stimulate and figure out where the nerve was. And we'd do a block together. And when the patient was happy, he'd take them back to his office and freeze them. Patient by patient, nerve by nerve, 1 at a time, 2 at a time. We're up to 20 nerves, 27 at a time now.
Wow.
So it literally was a eureka moment of serendipity. But at the same time, my goal was to create a surgical neurectomy program. I worked with an incredible plastic surgeon, and she had done cutting edge plastic surgery for spinal cord injury nerve transfers in St. Louis, Emily Krause. So the 3 of us worked together. We do blocks. Dan and I would try to figure out which ones we could cryo, and she did neurectomy and surgery on everyone else. And Dan would actually go to the OR as an anesthesiologist to help her. And he actually would look at the nerves, he would dye them, he figured them out. And then we'd come back to clinic and he's like, hey, Paul, we can actually do this. So Dan started figuring out how we could do the surgical procedures. And as we got better and better, the surgeon, she said, Paul, you can now replace like 90% of what I can do. So why would I do surgery and leave scars?
Right.
And it takes me hours to do 3 nerves. You just did 10 in the same amount of time.
Right.
So that's kind of like the Gestalt coincidence that just happened to have this. The best surgeon in America, Susan McKinnon in St. Louis, trains Canadian fellows because she's Canadian, and they come back. So the 3 of us working together with zero, I'm talking no money, no funding, no money, no OT, no physio. We started coming up with this new technique completely under the radar.
That is unbelievable. I mean, there was so much to that. I could do another 2 hours just on that, the follow-up on that one. From how it started with pain, because the things that are going through my head is, gee, it started with pain. I wonder how popular it was as a pain intervention. And then what lessons did you learn from pain and then apply to spasticity? And we'll get into spasticity in a minute, but and then you started talking about ultrasound guided, so that started getting my head going a little bit more. So let me ask you a couple follow-ups. So let's do anatomy for a second for some of the listeners. Some are, like I said, patients, caregivers, and some new grads. What exactly happens to the peripheral nerve during cryoneurolysis? You kind of started talking about that with that almost like a structural scaffolding that's intact, but
Right.
the outer layer has an issue. If you can spend a few minutes on that.
Sure.
And then also, clearly there's recovery with nerves. So how long does it take to recover if you do cryo? And then add to that, how important is, ultrasound guidance when you're looking at anatomical precision. So if you can just get a little geeky and take us to school a little on the nerve damage / healing recovery. And then, you brought up electrical stimulation a minute ago. You brought up ultrasound. Do you typically use electrical stimulation to identify that motor nerve, or do you use ultrasound, or do you do both? So let me stop there and get your opinion.
So those are really excellent questions. And just to preface your answer is that the current on-label indication in America is pain associated with spasticity, because spasticity is very painful. So even the person who says to you, Henry, you're working with I don't have a lot of pain in my shoulder. Ow! As soon as you move them to end range, they're in a lot of pain. There are so many structural causes of pain in spastic patients that almost everyone has pain if they try to get to that range of motion they're avoiding. So when we look at nerves all start as a trunk. So we have plexus, like the brachial plexus, the lumbosacral plexus. So they leave the spinal cord as nerves, but they often travel in a plexus. And at the beginning, they're quite undifferentiated. So if you look on it from this angle, you'll see a circle. And that's a mixed motor sensory nerve. And that, like the homunculus in the brain, what I learned from the plastic surgeon who's really changed my life, Emily did, was that even within the nerve, there is representation. So the brachialis is here, the pronator, the different areas. In the median nerve, there's a branch going to pronator, there's a branch going to FDS. It's already organized in the motherboard where those strands are going. So when you look at a nerve on ultrasound in a transection, like this could be the tibial nerve or the sciatic nerve or the median, it looks like this. So it is this yellow lining, which is the sheath around it, the epineurium, and then inside it is all the different structures. So you have the axon with it there, but there's blood vessels going through, there's microtissues, there's all this scaffolding. So when we do cryo, what we're basically doing is we are taking a cold temperature and we're putting a needle right there. And when I put the gas in, nothing goes into the body. It is a drug-free process. We freeze the skin just to make it feel better, but nothing is injected in the body. And when I touch the nerve, it is so cold at that tip. You grew up in Buffalo. If you lick a pole, you're not getting your tongue off. Yeah. So that moisture will lock it in place. So if I have a patient with cerebral palsy who can't stop his aphthatosis, it doesn't matter. I can't move. So what happens is at the temperatures that we use for cryoneurolysis, so neurolysis means to break down. Cryoablation, we ask people not to use that term. That's for tumors, that's for cardiac, when you kill the nerve. So in a phantom pain, someone after an amputation, you might do ablation because you want to get rid of it forever. So what we do is we do this. It does not damage the perineum, the epineum. It stays there at this temperature. The blood vessels, everything is okay. Andrea Trescott, who's really the incredible inventor of most of the pain techniques. She lives in Jacksonville, Florida. She's just an incredible person. She says it's like putting a chicken breast in the freezer. You can put it in there for 6 months, thaw it, and it's perfect. But if she puts it, she does radiofrequency ablation with heat. If I put it in the microwave to get the same effect, it's denatured and dead and you can't eat it. So cold does not have to damage. For just some reason at these temperatures, it breaks down. So if we open it up, this would be the lining inside, the myelin and the axon. So what happens is that the sort of the tip, which is the living nerve part, is destroyed. So the cells that make the nerve conduction are apoptose and break down. So they are gone. So they can't transmit electricity. So the pain is gone. You get numb and you get a conduction block. This is still there. So if I look from outside on ultrasound, it looks the same. This is still there. It's just the nerve fibers that are missing. Then what will happen when we do phenol, we destroy the nerve. We release neurotransmitters. We cause fibrosis. We thrombose blood vessels. It's toxic to everything it touches. It's a corrosive substance. It's like pouring acid. It does its job. This doesn't destroy anything else. So what happens is because the tube is there, the spine starts pumping its nutrients down. So the nutrients will go down to the point of damage and the little train tracks will start rebuilding. So you will get rebuilding of that. So in a really short nerve ending, let's say you're doing in the face, you might get 3 to 6 months. In a rat, it might be 3 weeks. But in a long leg in the body, it could last for a year. And we've just completed, and it's in revisions, paper looking at an H reflex, so a physiological response to a stimulus. And we found at 1 year, the nerve muscle interface was still suppressed at 1 year. Okay. So at 1 year, there was still reduction in electrical conductivity in that region, and the range of motion was still statistically improved at 1 year.
And is it still 1 inch per month?
Yeah, it would be exactly the same. And, the easiest way, to your point, would be if you've unfortunately ever had sciatica, like a true disc herniation, it starts with a massive pain in your back, unbelievable pain. And then your buttock stops burning, and then it burns down your leg, and then you get numb and tingly, and then you get foot drop or weakness of your toes. So you start with the lesion in the back, and then you get Wallerian degeneration down, and then you get foot drop. If you're lucky, over 2 years, the foot drop returns. And it goes from top to bottom, and then it has to grow back up. It's the exact same process.
Got it.
So we are inducing the damage.
Okay. And then thank you for the explanation. That makes sense. And then as far as you brought up electrical stimulation and ultrasound, and you brought up earlier, people are going in kind of blinded from when you think about history, trying to figure out the nerve. So do you use both electrical 100%. Stimulation and ultrasound? And if you could just describe how that works.
Sure. So, not a prep, but we literally wrote a book about all the techniques for toxin, ultrasound, phenol, neurectomy. This is how to do it for everything. And it's called the Atlas of Nerve Targeted Procedures. And the reason why we wrote it is because it didn't exist. And what we show is that, Alberto Eskenazi, one of the best spasticity physiatrists in America, he pointed out only 30% of people were using ultrasound to deliver toxin. And it's because of access, education, learning. But when I go in an arm like this to look for the flexor carpi radialis, where is it? My arm is, I'm in this rotated position. I'm in a flex position. Is this pronated or supinated? Like, it's actually hard to tell, right? Because I'm sort of supinated and pronated. So my location of my muscle is quite awkward to feel. And if they have, say, cerebral palsy or dense stroke, the nerve, a lot of kids have strokes in utero at 1 year old. We don't really see where that muscle is. And when you put it on ultrasound, you're like, okay, now I see exactly where I am. So with ultrasound, we know where we are. So it really shows you the location. But then we see unbelievable clarity with the newer models of ultrasounds, I can track the nerve so that I can see the median nerve above the arm. I will track it down into here. It goes below the pronator teres. It dives into the pronator teres, has a branch into flexor carpi radialis and a branch into palmaris longus. Then the nerve trunk goes down and it goes to FDS, it goes to FDP, longer to FPL. So I can literally track that nerve to anywhere I want. Then I take my electrical stimulator and put it in, we call them toxin needles because that's how we inject toxin. I put it exactly where I want, and then I try to at very low stimulation. So with toxin, we just want to know we're in the muscle and getting a response. We stimulate as high as we need to anywhere. With a nerve target, I put a really low stim until I get, so if I get this, I'm in pronator teres. If I'm going like this, no, I'm actually in flexor carpi radialis, FDS, FDP. So I am going to use the combination of surface anatomy, my knowledge, the position of the patient, my ultrasound guidance, and my stimulator to all confirm I'm in the right place.
So how do you determine if it's a sensory? Because I'm thinking again as I wrap up this first part. It started with pain, cryoneurolysis, and then
Mhm.
now we're transitioning to spasticity. Logically you would think with pain you're going to target the sensory nerves, and with spasticity the motor nerves. Maybe it doesn't matter, but do you have to decipher between sensory nerves and motor nerves?
It's the most important thing. So particularly when we started out, we the first thing we did was actually publish a side effect paper, because there were many people, when you make change, there's always people who doubt you. And the funny thing is, it kept saying, this is a pain technique. Why are you so obsessed about sensory when it's actually designed for pain? So at the beginning, when we were learning this, we didn't know how to find the individual nerve branches. And Dr. Eve Boissonneau, my fellow, and I, in 2021 in December, we met the French group again who talked about intramuscular targets, something we had never thought of before. So in a body, if I take out your sensory nerve, you will hate me. Like if I take out your tibial nerve, your foot will go numb and tingling, you can't walk. If you have horrible shoulder pain or rotator cuff pain, which is not there's no, the shoulder is more of a joint pain, I can knock out all the sensation to your shoulder and you will love me. You will say that was the best thing anyone's ever done to me because it's joint pain. We do the same to the knees. But if we do a median nerve or an ulnar nerve, or we do a superficial radial nerve or a tibial trunk, you go numb. So people don't like that. However, the magic of what we do is many patients with stroke have quite significant sensory neglect. So they say they feel, but if you do a sensory extinction, they only feel the right or the left. So if you have a hand, like a fixed posture, macerated skin breakdown here, we get a lot of calls from the therapists at care facilities. I've got a lady, her nails are digging in, she's crying in pain. We do an ulnar and median trunk block. So we take out all the muscles, all the nerves, and all the sensation, and you can just pry their hand open. They feel nothing. They're in so much pain that taking away
It's
their
a twofer.
sensation is much better.
Yeah.
A lot of them have dementia. So a lot of our strokes are that way, even a lot of our pediatrics, a lot of our MS patients, I can take away all the sensation on the bottom of their foot. And they're like, I didn't feel anyway, but now I can move my foot. So the decision tree to whether or not do a pure pain branch or a mixed trunk is a slam dunk. So a non-functioning hand stuck like this with the nails digging in, burning, I'm going to take out the ulnar nerve and the median nerve. But for someone who's stuck like this, I'm going to take out the FDS, the pronator teres, the FCR palmaris, and I'm going to leave their FDP and I'm going to leave their interossei so they can develop hand function. So we've become to the point where we are so hyper selective with our targets that it's super important to me if they're working with an OT, that an OT gives me like a recipe. Paul, I need this, I want them to have that, I want this.
Yeah.
This is co-contracting, this is getting in the way. Or you know what, Paul, if you knocked it all out for 6 months, I'd be super happy because I'm going to stretch it and move it and then we'll rebuild.
Right.
So it's like laser accuracy that we've developed.
That's good. Thank you. All right. Well, let's switch gears a little bit and now get a little bit more specific with spasticity. Obviously, as you know, it's one of the most understood problems and misunderstood problems in neurorehab. We throw the words around, it's tight. It's a mystery when it comes to therapists on what's the best way to treat these patients with spasticity. And some of them don't even understand the proper definition of spasticity. And I know that's evolving too. You saw the podcast I did with Monica as well. from your perspective, how are you defining spasticity clinically beyond the Lance's textbook's definition?
Mhm.
Because I know everyone kind of struggles with their own way of describing spasticity.
So Monica and I think very similar, and we talk. So she's an amazing person. And so I always start my papers with the Anand Pandyan's definition, because Anand Pandyan is not a physician, he's not an OT, he's not a physio, he is a bio engineer. And it is really a disordered sensory motor control. So it's an inability to control your system the way you want to. And whenever I start a talk on spasticity to people who don't know a lot, I always do the same thing. Something I developed many years ago because I did huge amounts of early intervention with toxin. So I always felt that every patient new in a hospital should get treated right away. And we had a lot of early intervention with toxin. So what I basically say in the position of spasticity, we talk about the upper motor neuron overactivity, but that's not the problem. The problem is the lack of inactivity, the inability to shut down. So again, yeah, I'm fine and relaxed in the morning. When my therapist stretches me, it's great. So for me, the biggest factor is that you can't relax what you want to. So I do the same thing for everyone. I say, make a fist, dig your nails in as hard as you can until it hurts. And while I talk for the next 5 or 10 minutes, I'm going to get you to reach out and pick something up, but resisting with every ounce of your being to prevent you from opening up. So in my simple mind, spasticity is the inability to relax muscles to let them know what their automatic reflex is to do because of co-contraction of unwanted movement. And why that's important is because we don't think when we move, right? We move. And we can't. But the problem with the Lance definition is paralysis is a huge component of that. So it's not just that you're spastic, it's you're paralyzed. So you have a paralysis of complete. Some people have very little paralysis, some people have catastrophic. So you have a paralyzed muscle that has resistance as well. So in the ultimate definition for me, if I had to simplify it, I would say spasticity is a disorder of a muscle to relax so it can contract the way it wants to.
That's a good way to describe it because it is obviously you want to shut it off and inhibit that reflex response, and you can't. And people sometimes think it's more of a muscle problem when it has nothing to do with the muscle. It's a brain problem, where it's the muscle's the victim, right, in this whole
Mhm.
situation. Or I'll describe it as um, the muscle is perfectly good hardware working with really bad software. So
Mhm.
there's a lot of different ways to describe it. So I love that the way you came up with it. Now you brought up you kind of mentioned a little bit about the different interventions that physiatrists and physicians can use for spasticity treatment. And for some of the audience, they may have heard of Botox,
Mhm.
or they may have heard of, I don't even know if they've really heard about phenol. When it comes to cryoneurolysis, where does that fit in with the overall spasticity management spectrum? I mean, is this like top choice? Would you go right to this after Botox fails? So if you can kind of just take a 1,000-foot view,
Mhm.
um, when a patient with spasticity comes to the clinic, what are the common treatment interventions that should be considered for that individual? I know they're all specific based on their personal needs. But what are the common ones? And then where does cryoneurolysis fit in? Last resort, first resort? If you can kind of share a little bit about that.
So if this was Dragon's Den and I was selling my product, like I'm coming to it with an incredibly biased view because I'm researching. And I'll preface it by saying, believe it or not, your podcast is called The Plateau. Well, our first study that we finally published, because our studies are 1 year follow-up. They're very, very long compared to any other type of study, it was called The Refractory and Plateaued Patient. Because in order to try something new, ethically, you had to try people who had failed every other treatment.
Right.
So we got the worst of the worst in our study, like the people who had no hope, had stopped treatments, nothing was working. And believe it or not, I convinced, because I'm not at a big academic support, I convinced the company that makes Botox, it was Allergan AbbVie now, to fund it. Because I said to them, you have this huge percentage of patients that fail therapy and stop taking it. And they know in the US right now, Dr. David Simpson in Mount Sinai in New York showed only 10% of people were still taking toxin after 2 years. So the retention is poor. And lots of factors: poor muscle selection, reimbursement issues, cost, availability of treatment. Are we choosing the right treatments? Do we have enough? For me, I am a researcher in something that I have developed. So I do as much cryo as I can, have as many patients and studies. I will tell you, and quite honestly, toxin companies come to visit me all the time. They send people to come train with me. They have been incredibly kind because we are advancing the care of the refractory patient. They fully understand that I'm using more cryo than toxin for spasticity. I do cervical dystonia. I do a lot of migraines with toxin. I'm still a user and believer and a lot of early intervention. For me, the cryo is a more like surgical intervention with much more extreme outcomes. So we are now a tertiary care referral center. So my colleagues from around the province, from around the country, from the US, are sending patients to see me who are not getting better. They've undergone their standard of care. We know that the cycle for toxin is 3 months. They are all working with their therapists, and they can't get better. So for me, the vast majority of people are coming to me have already failed all of the above. Phenol has never had FDA approval for spasticity. It's a corrosive substance. You can't use it in Germany because the Nazis like to kill all their enemies with it. Botulinum toxin was developed as a biomedical warfare by the US military in case someone used it as an attack. It was a good use, and toxin does wonderful things. We use it for medical good. But both of them were under the category of biomedical warfare. And a lot of patients don't want something dangerous or toxic. Cryo is physics. So I have a lot of indigenous patients here. And for an indigenous population that was, the British wiped them out with smallpox, purposely trying to kill them, well documented. We're saying, no, we're going to use the power of nature to cool you and heal you. It's a totally different reason. So when we go back to this a long-winded way to say, when I'm doing cryo, people are sent to me for cryo. So in my lab, I get referrals all day long. The more medium coverage, the more patients that come. Can you do cryo on me? For me, it's a much more powerful tool. My patients have MS, they have quadriparesis, they have severe tone. There's the on-label limits for Botox in America is 400 units. Xeomin, which is another brand, which is about 600, and Dysport, a different value, is 1,500 units. And none of them are satisfactory enough to treat all of your body. So for me, it's natural. There's no toxicity. It's harder to do. There are definitely difficulties with side effects, but it's instant. And one of the things why you were drawn to my LinkedIn posts is we spent a lot of time in closed rooms bawling. It's very emotional. I even just talking to you, I'm probably going to start to cry. It is really emotional when you do a treatment and the husband grabs the wife's hand and they walk away holding hands. Or a kid gets up and hugs his mother. Or a 10-year-old sends you a video running up and down the stairs. They've never gone up and down a stair once. And because there's no recovery time like surgery, some people have pain for 42 hours a week after from the procedure. It's so instant that it becomes like a dopamine excitement for everyone in the room.
Right.
A lot of the therapists come here and bring their patients with me. They spend the day, they watch the treatment. So for me, to answer your question, is I'm trying to see how far we can go. So one of the reasons why we're so meticulous about our outcome is we do the nerve blocks on everyone. So if you come in and want to know what treatment, I will do a nerve block. And if it's a very simple hand function with this, I will do toxin because it's a great choice. It's small, fine motor. I can do this. I don't have to worry about hitting a sensory branch. If you have a lot of cramping and spasms that you want to just relax, toxin's great. A lot of the cervical neck problems, toxin's great. Early intervention, they're developing a little bit of tone on the ward. The therapist said, Paul, they're Ashworth grade 1+, but it's getting in the way. Toxin will work fine. But as soon as there's a lot of joint pain, and hemiplegic shoulder pain is the 4th most common complication of stroke, the leading pain syndrome, we're going right to cryo. If they are contracting, so they get out of bed and they've got gender recurvatum and they're already developed a contracture, they can't extend their elbow 2 weeks post-stroke, I'm going to cryo. So for me, I'm very biased because we're trying to do cryo for everything, and it's such a a slam dunk victory. But I would never say to anyone else, you have to do cryo.
Right.
And many of the patients traveling 4-6 hours flying to see me, we will do cryo to knock them out. And then their doctors will go back and continue with what they have in their area, which is toxin and therapy, which is great.
Yeah.
So, but when we started out, when we first did our studies, we couldn't do every muscle in the body. So, last week I had a 5-year-old with a birth stroke. And I went right through here. I work with Josh Fova in Atlanta, peds, and his thumb is stuck in adduction. So I can now go in, knock out this without taking out a sensory. So we have been able to do spastic toe curl, claw. We can do almost any pattern now, with the exception of some small muscles in the hand and feet. So for me now, I can do cryo almost anywhere. I don't want to bias myself. If the patient wants toxin, that's wonderful. The difference between Canada and America is I have a fridge full of toxin. So if the patient wants it, and particularly if they don't have high income, it's free. Yeah. So we don't have the limitations of America. So it's so simple for me to use toxin here.
So thank you for sharing that. And I can imagine there's a differentiation on when you would do toxin versus cryo based on your experiences. Going a little bit deeper, if for education purposes, you kind of really did a good job explaining, okay, you're going to take this cryo probe, insert it, identify the motor neuron, the nerve you're looking for, and that's when you will form the ice ball, which then damages the outer layers of the nerve. How does it work for Botox?
Sure.
Just real quick, because I know a lot of people understand Botox.
Excellent question. So Botox blocks at the neuromuscular junction. So it stops the release of the acetylcholine from the binding. So there's a whole bunch of things called the SNAP25 protein. I hope I'm getting it right. And there are receptors. So when you release acetylcholine, you send in a vesicle that's going to go to your membrane of your muscle and your nerve interface. And then that nerve impulse is going to go from one to the other and cause the area. So that botulinum toxin binds to that protein and it stops the release.
So is it hard to find the neuromuscular junction compared to?
No, because it's such a brilliant chemical. Toxin is a brilliant chemical. 1 gram does the whole world supply. It's a nanogram supply. So toxin is very forgiving. If you inject the muscle, it knows where to go. It has a homing device. So the reason why toxin is so effective is because you just have to inject it in a region and it will migrate to its target. It's designed with a homing device.
Got it.
So it blocks that signal. So you don't get the nerve control. And then what happens is the nerve itself will resprout. So it will resprout. It will make new connections. So the conductivity comes back at 3 months. And what they think happens is the new ones actually die off and the old one resprouts down better. Okay. So toxin is blocking the neuromuscular junction of chemicals release. We're actually destroying the conductivity. So that's what neurolysis is.
Got it. And from the cryo's benefit standpoint, it sounds like it happens immediately, lasts a lot longer, can be considered safe because there's no toxins going into it. Explain, and we know the indications. Thanks for sharing that. If you don't mind, with cryoneurolysis, explain the contraindications. I guess who's not a good candidate and some of the adverse symptoms or side effects that people might want to know.
So in theory, the contraindications are cold urticaria, which is a hive to cold. We just did a child last week. I just put warm towels on because they did an ice challenge at the allergist. She gets hives. So I just really warm them up with a blanket. We put very warm cloths around the skin. It's just one local ice ball. So it's not like your whole body's getting cold. It's been no problem. People have talked about Raynaud's phenomenon being but it's the same thing. We're not injecting in the fingertips. And in fact, cryo is a treatment for Raynaud's. You knock out the sympathetic ganglion. So it hasn't been a problem. It's a lot more painful. So if you're doing a spinal cord injury and they have no sensation, a lot of our stroke patients have very little sensation, but it can be painful. So when it's a much bigger needle, but when the muscle cramps, you get a Charlie horse. So we go from people who have this is no problem to people screaming. And we warn them that. In a perfect world, I'd be able to give a sedative to every patient. But we can't. We'll give them some Ativan. We have a special thing if I'm an anesthesiologist here, like a gas we inhale that we have in Canada, you don't have in the States. And with kids, we do for full sedation. My adults with cerebral palsy, we've just started a anesthesia clinic as well for that. A lot of kids get their toxin under sedation. So it is more painful. So if you can't tolerate it, and some people have severe pain with their stroke, it's part of their condition. However, we have lots of ways to mitigate that. So what I can do is if they have a lot of pain, I will do a lidocaine block first. So I don't want to do a lidocaine block because I want to see the cryo work. So if I'm doing the bicep, the brachialis, I want to see the arm open so that I know I need to do brachioradial. I want to see it in real time. But if they have too much pain, we just inject lidocaine and then there's no pain or reduced pain.
Okay.
The side effects that we had we had like one patient ever got a little bit of skin infection, but they're just prone to that. It's so cold, right? It's like antimicrobial. The other side effects we've had, if they're on a blood thinner, we have to be careful when you're going into deep structures, but that's a bleeding effect of the treatment as opposed to the cryo. So if they're on Coumadin, we have to ask them to hold off, but do a lot of people that are on Coumadin or warfarin. The main side effects we had, and when we did our study of 113 patients, 277 nerves, we had 9 patients that reported a side effect of 113.
That's really good.
5 of them asked for treatment. So small amount. The treatment is painful. So if you have pain with the treatment or some bruising or pain after, that's just a treatment reality. It was just part of the procedure, but when we called a side effect, when the actual cryo caused difficulty. And at the beginning, we realized that what was happening was some of them needed like some gabapentin or Lyrica to settle them down. A couple needed a cortisone injection. But what we realized, the reason why they were getting a side effect is we did not lesion a sensory nerve enough so that the nerve was still firing, causing pain, or we were like going after one of the branches to the gastrocnemius. And what we didn't know at the time is you have the 2 heads of the gastroc. Well, right where my fingers meet, there's a sensory branch. It looks like a cat's eye of the sural nerve that runs through there. Didn't know that. So when we'd go in, we'd inject one and then the other. We didn't realize that we were partially freezing the sensory branch. So they got an incomplete lesion, and it's quite painful. It'd be like listening to your music and there's a cut wire. You hear the music with static. So we felt terrible. So of all those patients that had side effects, complete numbness was a nuisance, but it didn't cause pain. People who had pain, we felt like it was the end of the world. Like I really hate when anyone has a side effect.
Right.
So we've been able to really reduce the side effects by 1, avoiding sensory nerves when we need to. But if someone were to call back and say, hey, my foot is burning, I'm going to bring them in and make sure it really is the cause. And then I'm just going to cryo it again and the pain goes away because we've gotten rid of
the nerve, right?
It's gone.
Yeah.
And I'll say, unfortunately, the top of you have an aberrant innervation. For some reason, you have a branch of your superficial fibular nerve going through there. I don't know why, but we got it. So you're just going to have a numb foot. They're okay with that. Nobody wants pain. It's hard to walk when it's the ball of your foot. Other people, have had a couple, like particularly when I do a tendon release at the same time, they've had hematomas there. So when I literally, so every time someone calls in, they're told, call in urgently. And one of the most fascinating thing is my physio will often see them for me as well. It's like, Paul, she has a ton of foot pain after the procedure. It came on a week later, but it's her plantar fascia. She's now dorsiflexing so much, I can feel the rigidity in the plantar fascia. They will get tibialis anterior pain because we've treated their equinus foot and now it's firing. So I'd say half of the pain complaints that I get after are because we stretch the shoulder. We did a lot of extra movement. They were working really hard in therapy. So it's such huge change in function that what basically happened is half the complaints are just part of rehab.
Right.
And we're really working on educating our patients before. We're making videos on this to know what to expect. But other kids go to dance class. People tell me I went up and down 12 flights of stairs yesterday. I went to Vegas, so there's a lot of people, most people won't have a problem, right. But I'm never going to say this is like easier and better than Toxin because it isn't.
And you brought up,
but with Toxin, people have died of dysphagia. They have had spread. Like every medical treatment will have a complication.
Yeah. And you brought up physiotherapy. And that's one of my biggest concerns in rehab is when an intervention is done in isolation without being paired with treatment. What's the ultimate goal? The ultimate goal is to reduce spasticity. These interventions are obviously temporary. So if we want to make permanent changes, it's going to start more in a neuroplastic way. and that comes down to the PT and the OT. How should therapists integrate cryoneurolysis into their therapy? In other words,
Mhm,
when a patient undergoes the treatment, how should the OTs and PTs
mhm.
adjust their intervention plan to really capitalize on that temporary window with the spasticity reduction, from your opinion?
Well, the nice thing I will tell you, it is the most complimentary pattern that my therapist feedback is they love it. So we get called all the time from our inpatient units, from our outpatient, from the community therapist. I have this patient, can you help me? Because they can be so specific. So Paul, they have a short stride and they're co-contracting their hamstring at the same time as their quad. So they can tell me that because they're working. I'm not working with the patient, right? I met them once. So therapists have a much more innate sense. And then sometimes I'll call the therapist, do you know what? They're stiff knee gait. When we did their quad, their hamstring went to 90 degrees. There was no resistance. It was a co-contraction with muscle contraction. And the other, I'm like, I had to do their quads, their adductors, and their rectus because it didn't shut down. So for me, the very first step that I want the therapist to do is stretch, 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 stretch. I want you to get the patient to the end range of the joint so you can now work with them in a lengthening position. So they've been stuck in this position, right?
Right.
And I now have them here, which is wonderful. I want you to do posterior mobilization. I want you to open up that capsule because all the other muscles we didn't treat are still pulling. I want you to back, abduct, get them here, force their fingers into full dorsiflexion. I want you, because these are still stiff. They haven't moved in 10 years or 20
Right.
years or ever in their life. So my first step for the therapist, please get the length because we can't generate power if we don't have length. And it's a bit of a contra idea that, when we're like this, there's two problems. One is what we're flexed, but two is our extensors can't fire because our extensors have not fired in a decade because the
Right.
fingers are in this position.
Right.
So what I'm going to say is I want you to stretch up and break up all that scar tissue. You're going to be like this. You're going to have to break up the capsule because now the capsule is tight. The joint is stiff. The sensory is stiff. All those things are there. Now I want you to put on e-stim and I want you to do some functional stim. So it just, not even to give them the power, just to get used to electrical impulses because the brain has been saying, go away. Like,
Exactly.
why are you sending me this signal? I can't use it. Suddenly, the hand is here. So I want you to use that stim just to get used to the connection.
Right.
And then I want you to do facilitated. That's why for me, extension assist braces are so important because the brain has forgotten how to do that pattern. So it really allows the therapist to start working so much more fluidly.
Right. And the thing that you brought up regarding, because there's a lot of old theories, and depending on when you graduate, when it comes to therapists, when it came to spasticity, they thought weight bearing and stretching was it. And obviously, we all have stories of spending 25 minutes weight bearing with a patient, and then get them very loose, and then have them only to walk to the parking lot to get in their car, and they're drastically tight again. That was a waste of a
Yeah.
treatment.
Yeah.
So stretching is definitely a component, and there's obviously evidence to suggest that you can increase sarcomeres in series with low load prolonged stretch. In a lengthened position, you can also reduce sarcomeres in series if it's in a shortened position. That's well documented. Part of the problem is they stop there and they don't do what you just said, part two, which is the active movement, which is just as important, if not more important. Well, certainly more important. And so, how you do that is number one, in my opinion, they're not stretching long enough. And that's where tools come in. There's a lot of dynamic orthotics out there that can help with their spring loaded, or some are not, some serial casting. That has to be done aggressively,
Mm.
coupled with, to your point, yeah, I like to do electrical stimulation a lot. So you took the example of spastic flexors. I'll put the stim on the wrist and finger extensors and splint their flexors. So you're getting stim while stretching
Mhm.
the spastic flexors. And remember, there's a little bit of an agonist antagonist thing going on here where you're learning to shut off the flexors as you activate the extensors. And then, of course, that's again just one piece of the puzzle. Then, of course, active movement. And so getting the brain to remember that this hand exists, engage that hand. Some of them have no volitional extension. So,
Mhm.
of course, you got to start with e-stim and bracing. But if they start to have that volitional firing, then, of course, the next logical step is coming up with using the neuroplastic principles, engage that limb into purposeful movements. that will then fire shoulder, elbow, and hand. So there's a lot of seats at the table when it comes to reducing the spasticity from a therapy perspective. I think when we harm our patients the most is when we only do one of those things, whether it's stretching only, whether it's bracing only, or whether it's just active movement and forgetting to do what you said, waking up the joint capsule, stretching and trying to reduce the contracture. But folks, it's not going to work with 3 sets of 10 for 5 second stretches. It's going to take a lot more than that. And so I think that's part of that important component. Functionally, can you share one or two stories where you saw, this is for the OTs and PTs, where you saw like massive functional improvement?
Yeah, and as I go there, I just want to remind you the reason why they tighten up when they get back to the car is because we never shut down the neural system. So we know that there's really good data, studies from Australia, that stretching does not reduce spasticity and rage. But we've actually gotten rid of the tone. So the reason why for me, step one after my treatment is stretching is because the tone is gone. It's going to maintain. So if you actually stretch them, they don't shrink up again. And it's the people that are non-functional that will tighten up when the procedure runs off at a year because they haven't stretched. So for me, we have a lot of sort of miracle kind of outcomes. And, at the beginning, people would say to me, I remember Gerard Francisco, who's an amazing innovator in America, who's very supportive. And he asked me, I kind of think a bit tongue in cheek at a meeting, how do we know you're not showing us best case scenarios? I'm like, I show you my worst case scenario all day, every day. This is like tenotomy after cryo. Like we are taking the worst possible patients and presenting them to you. I'm not even showing you the good cases. So when someone comes to me, it's very important if they want to fly here from North Carolina that I say, well, first of all, my team, I'm not allowed to do cross-border medicine. My team is going to assess you and say, you don't have a functioning arm. So we are going to relax you, you're going to do this, but we can't give you back power. The patient really needs to understand that we can't fix the paralysis piece or the dystonia that makes you do this. But in terms of the great cases, I live in a small community, so I'll literally have a couple coming in for something else and go, hey, my neighbor's that little boy, he got rid of his AFO, he threw it up on the post, and he runs into our house all the time. We do have patients, and we're going to be publishing a paper, someone who's a 40-year-old who has not been able to use the hand functionally, who day one is, I've got videos that I show. She's throwing a tennis ball. She's doing a not slamming, but she's dunking a basketball. She's feeding herself. We have many people that have tone that interferes enough so that they have a severe claw or a dystonic movement so they can't use it, and they're suddenly using it. For me, a victory, one of the funniest things is I have a boy from New Jersey, and I get videos all day long. So when I can't even come up with one because my phone is literally full of hundreds.
That's great.
And I'm literally flying to the US, and just as I get through customs, there's a picture of a 12-year-old boy sitting on his bed with a deodorant stick going like this.
Awesome.
And the family is clapping. I'm like, guys, I'm deleting this. I'm going through US customs. This looks absolutely horrendous, but I'll get back to you in an hour. It was so funny, but for him to put on his own deodorant, so people doing their own zippers, I have a lot of videos of people doing their hair, touching their hair, touching their face. So imagine you haven't felt your hand in 20 years.
Yeah.
For me, we treated an 87-year-old with CP last week. We have people who get admitted to hospital with a worsening of their underlying condition, who can't walk, who go home the next day. Because not only are we treating their tone, we're treating the osteoarthritic knee that they're standing on that won't bear weight. So for me, it's self-feeding, brushing your teeth, putting on your glasses, hugging a parent, to really good fine motor. We use a lot of box and block test as a measurement. So you can go from like 12 to 30 or 20 to there, a 10-meter walk test that goes from 40 seconds to 20 or even 40 to 25. So we are constantly having these successes. And I will tell you, I was at an AAPMR meeting with a group of American experts, a little bit all sort of long in the tooth, said to saying, well, no, you need to tell your patients when you treat them with spasticity, you can't treat spasticity and get more function. And I was sitting there with Dr. Mike Munin from Pittsburgh going, he's a big phenol combo with it. And we're like, what? Like, Are you telling me that you can't get more function with spasticity care, which is nonsense, because
Right.
all of us with toxin, with everything, when you live that life. So for me, there are many miracles. It's the patients that send letters all the time. This is a miracle on my life.
Yeah.
And it might be something small, but it's literally the difference in independence, being able to drive, be able to shower yourself, being able to dress yourself, being able to cook breakfast for your kid. Like these are the miracle. Being able to walk without a brace. Those are the functional gains every day, because we can't take away the stroke. We
Yeah.
can't take away your MS.
No, that's fantastic. And you're right. Even as a therapist, it's those little small victories that are massive. Shaking a hand, getting the arm out of the way when going to the bathroom. Just the little things you don't think
Mhm.
about. So we only have a couple minutes left, and I really do appreciate all your time today. This has been a fascinating discussion. Couple last questions for you here. Where do you see cryoneurolysis going over the next 5, 10 years? I mean, you're just with spasticity specifically, you're
Mhm.
just at the beginning stages, and you guys have done phenomenally with exposure, treatment,
Yeah.
articles. Where are we going 5, 10 years from now?
Yeah, it's a really exciting time. So we just had a nice review paper come out in PMR Clinics. Our physiatry textbooks, so Bradham, Frontera, which are the big Bibles made in the US. The people writing the books now are cryo. So like America's top people are all either doing cryo, many of them, or they're part of our randomized sham control study in about 18 centers in America. So we're now in the stage of FDA approval, Health Canada approval, European label approval. It's much easier for a device than a drug. So it has gone so fast that I want you just to understand that in America, no toxin has ever had approval for the shoulder muscles. So even though the 5 positions of the stroke are the adducted position, 4 of the 5, almost all, it is not on label for those muscles.
Huh.
The most physicians in America are injecting off label all the time because there's no evidence it works.
Wow.
We use it because we know clinically it works,
Mhm.
but no one's been able to design a study to show significant functional change. When we do cryo, we're using the Tardieu scale, we're using pain, we're using many things. We're seeing it, we're showing it. And if you notice, every paper I do always has a video to go with it to show that change. It is skyrocketing now. It has reimbursement strategies from Medicare and insurers in the States. We are now over 75 centers, I think, around the world doing it for spasticity. So we are now going mainstream. So every conference I go to that talks about spasticity, or a friend will always send me a text from Istanbul, from India. They're presenting your paper or another paper. It's now become part of the nomenclature. And you don't hear about phenol that often, right? You
Right.
mentioned there. I love intrathecal baclofen, but it's so inaccessible where I have. It's very geographical and it's a very specific. So what I think is going to happen is we're completing our sham controlled study in America. There's many studies coming out from Europe that we're working on. There's brain control. We will have way more evidence than Toxin ever had. Toxin got its label, and unfortunately, the way that the FDA approved at that time, it looked at specific muscles rather than overall. Toxin should have general approval for everything because Dysport has the biggest label by far, and in Canada, our label is much more generous than America. Um, I just think it'll become a tool. Now, not everyone can do it, but one of the biggest factors that I've had a lot of support from my provincial government, my hospital right now is paying for our treatments for the public. We published a case report this year on an MS patient getting 600 units of botulinum toxin every 4 months for years. Now, understand, in many countries and many insurance do not pay for toxin in multiple sclerosis because it's never been shown to be effective. The dose of 600 is also not on label. The muscles being injected were not on label, and the person was not getting better. We saw large functional gains. Again, it's not an arm she can use, but pain and relaxation, standing transfers. The cost in Canada for the one treatment, we did 2 treatments 18 months apart, was about 410 American, I think, for the treatment. We calculated in Canada that would be about 6,000 US dollars to treat, but in the US it's $15,000 if you get the cost price. So 15,000
Nice.
versus 400. However, that's the cost price. So when we costed it out at Yale, at Houston, it was over 35,000 they would charge the insurer. 35,000 versus 400.
Wow.
Then you have to talk about the facility fee. So going 4 times a year to, your University of Michigan clinic,
Right.
you're going to $100,000 a year for this treatment.
Right. It's a lot.
Americans traveling to come see me tell me I pay $5,000 cash 4 times a year after everything else.
Yeah.
It's 400.
That's amazing.
So it's the cost will be a major factor to support it on top of all the evidence, because insurers and governments like to save money.
So hopefully it's going to be a lot more accessible 5-10 years, obviously
Yes.
more advanced. All right. One last question for you as we wrap up. If clinicians can remember one key principle regarding today's talk, you can narrow it down to one in spasticity, what should it be?
So we will continue to get better. There will be other techniques that will continue to get better. There will be implantable robotics and techniques that help. And what I want you to remember is that there's contracture, which is the end range of a joint to expand, and there's spasticity. And that's what you and I were taught, but that's not true. Because every patient that you thought had a contracture, you won the war, Henry. You got them stretched out. They woke up in the morning and they said, look at my hand in the morning. So there's a huge percentage of people that get deemed contracture that have a reducible deformity. If your patient has a reducible deformity, you can do so much more than you think. So if you can figure out who has those reducible deformities, there are people I can reef-on their arm and we do cryo and boom. We know that because we do a block. Yeah. So the take-home point is that we don't quite understand the difference between tone and contracture. Tone is a wonderful thing that we can modulate.
Yeah, that is absolutely right. And I know there's some confusion over that. And I know with different assessment scales, it gets a little bit easier to differentiate. And there's benefits, functional benefits for having some level of spasticity throughout the day or tone. What is your recommendation then for clinicians wanting to learn more about cryoneurolysis? Is there a go-to place for them to go?
I'm developing a lot of
Where can they go?
education. Yep. My thing is free global education. So I spend every day trying to get grants from companies, toxin companies, cryo companies to allow us to do free education. We are creating the literature as we speak. More and more American centers for your audience are doing it now. Some are just actively recruiting patients. There's difficulties with state lines, I hear. I have a spasticity map that I will show you. It has a map of every clinic in the world taking patients. There's a whole bunch in the US that are also just doing it for the study, and they're waiting to get institutional approval to open it up when the study's closed. Okay. So it's still quite, niche.
So follow you on LinkedIn is the best way to stay updated.
It is the way. And, I feel like sometimes I'm a yenta. Like I'm the matchmaker. Like people are constantly in India where I need this person. And like in 2 minutes, my colleague from Australia is like, I'm going to visit family in the Philippines. I'm like, call her. She's at the National Orthopedic Hospital. She's trained with me. Her husband's an ortho surgeon. Like, how do you know all these people? Because I know people. So I want to be that yenta and put everyone together and make those matches.
Yes. Well, I think that's great. And of course, I know you're going to continue to produce out great videos. I'll keep making noise about cryoneurolysis as well. And I'm sure that it's going to grow over the next couple of years as far as a database. So in the meantime, Paul, thanks for all that you're doing to move recovery forward. You are a true pioneer and a great communicator of knowledge, purveyor, spasticity, and keep it up. I really appreciate your time today. And I think the audience definitely learned a lot. So thank you so much. And for your commitment to recovery clearly permeates just having this brief conversation. I could tell you your patients and the colleagues that surround you are very lucky to be in your presence. So keep doing a great job.
Thank you. It's a huge honor. And it's something that what I think is because it's so tangible. Like if when you come, you're going to come visit us, I hope, absolutely. And watch treatment, you will be really emotionally overwhelmed. Absolutely. You will, by the end of the day, you're going to go home and shake your head and you're going to have a little cry and you're going to be like, I can't believe what I just saw. What I wanted happened.
Yeah, absolutely. I'm excited and can't wait to come to your neck of the woods and see this firsthand and figure out ways to help these patients. So thank you so much. I really appreciate it.
All the best. Thank you.
Thank you.
Thank you for tuning in to the No Plateau podcast. Please make sure to like and subscribe to stay up to date on more stroke and brain injury recovery stories. The No Plateau podcast is intended to give you an insight into stroke and brain injury survivors' journeys. Any opinions given on this podcast are strictly the individual's, and we do not suggest that you necessarily hold the same viewpoints as anyone on this podcast. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Reliance on any information provided by the No Plateau podcast is solely at your own risk.